we, as a headache clinic, we often deal with, we're following these patients longitudinally they often have migraine, and then they've had Chiari or have a history of Chiari. And some of them have been decompressed, but particularly if they've been decompressed, they'll come in complaining of worsening headaches, and they'll say, Dr. Martin, how do I know it's not the Chiari decompression going bad or needs to be revised? So we'll do, the Cine studies looking at spinal fluid flow across the cranial-cervical junction, and then there'll be different interpretations by the radiologist, like, well, there's a mild anterior decrease, a mild posterior decrease, a moderate to severe decrease, and as headache doctors, we just usually refer them back to the Chiari doctor, and it becomes up to them as to what to do in this situation. So I guess the question I have for you is, when should we be concerned about needing a revision? Obviously, if there were severe deficits in CSF flow across the cranial-cervical junction, that would be something probably most people would pick up. But how do we recognize when Chiaris need to be revised? And then the second question is, obviously you can get the pseudomeningocele, and I think you can get arachnoid granulations. I suppose you can get scar tissue there. What's the best way to evaluate? Is it just with the Cine MRI, or do you need to do myelograms, or how do you think it's best to evaluate these people that need revision?
Yeah, great question.
Oh, I can. Well, I would say enlarging syrinx is one. I think that all neurosurgeons would say enlarging syrinx would be someone's already had initial Chiari surgery. An enlarging syrinx probably needs a revision, especially if it becomes symptomatic from that. Any new onset symptoms or recurrent of symptoms, that would be someone to be indicated for maybe Chiari revision. Imaging is critical, right? I mean, you would look at that as, is there still after the first surgery? Dr. Keating mentioned, adhesion, scar tissue can form intradurally. Was the PIA violated, right? And you get all that adhesions that can occur, right? And then you'll see brainstem sometimes scarred to the dura. You'll see outflow obstruction, brainstem still compressed. All those cases probably, need a revision. Of course, the neurological exam is important. Patient's doing perfectly fine. Imaging shows an abnormality. Well, then that's a discussion. But I mean, most of the cases, you're treating the patient, not treating imaging.
Is Dr. Yang still here from yesterday? I was just trying to look for it.
Maybe I can answer this question.
Yes, please. Dr. Gray, our neuroradiologist.
Extraordinary.
So, I wonder if you can't start with an MR scan first after, having Chiari surgery. If that still raises questions, I would guess that doing an MR scan at the cranial cervical junction would then be the next step to go. So if you can't answer it with just a CSF flow study, because those are, they are subject to interpretation. And so, there's not really a defining thing. You can't exactly measure the volume and the flow, and there's lots of artifacts and stuff. So I think if that doesn't answer it but raises suspicions, then probably go on to a CT myelogram.
While you got the mic.
Yeah.
So Cine MRI,
Yeah.
has been something that, patients will come to me and says, I need a Cine MRI. They actually say, I need a Sign MRI because, Cine is cinema. But it's so fraught in Google, that you have to do a Cine MRI for Chiari. And I have a very tough time interpreting outside Cine scans because there's so much issue with what their control is, and it's a difficult, murky area in terms of proving is there good CSF flow. So one, I'd like to hear from the expert about Cine, and then the panelists about how you use Cine MRI. So,
I mean, I would say in general, it's really variable, and usually it's set to a velocity encoding number. And so like if the velocity, it's set at like 5 centimeters per second. And if you see that and you see white flow, then it means that you've got good flow. But if it's dark, then is that diminished? I mean, it's just so ambiguous. So I think if you really have a question, the best thing is really a myelogram that looks at the cranial cervical junction. I think it's just too much variability.
No, thank you. Any comments on how you use Cine in your practice? Or
Yeah, widely variable probably amongst neurosurgeons. I never get a Cine flow study, mostly because it's subjective. There's no established criteria what absolute full great CSF flow is. You have radiologists that will interpret them in widely varying manners. And I think it's just more important to evaluate the patient, neurological exam, their symptoms, and other aspects to the MRI imaging.
Dr. Heiss.
The most important study I saw was from Hopkins,
Not on for some reason.
but was from Hopkins, and what they showed was patients with normal CSF flow before Chiari surgery did poorly. So it's a good way, if you have a normal cine before surgery, you shouldn't have surgery.
Yeah, this has evolved. I mean, when I was a resident, Rich Ellenbogen, like there were a lot of studies out about cine and how we were using that. It was just being developed in MRI, but we've had patients from their report, saying no flow, and they think that's an emergency. That there's a medical emergency if you have no CSF flow back there. It's not blood flow. This is spinal flow. So is there any urgency when you see that? Does it make you nervous about timing or anything when you see no flow on a report? Just it's an important issue that has come up repeatedly.
I would say
Someone who never gets a
I never get a city flow. So now I would say never. I get them maybe very occasionally.
Okay.
Those cases where someone's adamant that I'm like, I can show you that it's normal because I can tell on an MRI without the cine whether there's flow obstructed. I feel like I can. And so I'll get the cine flow just to show that it is. But that comes up rarely just because I don't get them. But I don't think it would be an emergency. I think you can interpret that slow flow. They would have hydrocephalus, right? You would see other things, and you don't typically see that. Obviously, unless hydrocephalus, that's more of an emergency. I'd be more concerned about that than a cine flow study showing absolutely no flow, because I'm sure there is some flow. You just don't see it on a cine flow study.
Dr. Martin, any disagreement or
No, I think that's very, very reasonable. So.
any of the medical folks in the audience disagree or use cine in a way that's different than what we're describing? Can you get Dr. Keating a mic, please?
Yeah, I think we all agree there's a lack of objective data on this. On the other hand, if somebody has a classical presentation for Chiari and their flow looks poor or there's no flow, and you do the surgery and they do really well and the flow is reconstituted, now it's very different from what was pre-op, and then 5 years later they're having issues again and now they have no flow, and then you're probably comfortable that they probably have an issue with scarring or whatnot. If they have great flow, then it's likely maybe something else, especially when you're having a large number of patients with hypermobility, and then the trick is figuring out what's related to the Chiari versus what's related to the hypermobility. So I think the subjective part of that can be used to help in the long run if you're trying to look at somebody down the road and they're having issues.
Yeah, great point.
Jerry, I have one more thing.
Yeah.
In people with Syringomyelia, not Chiari related, if there's no flow in the syrinx, that's unlikely to be remediated or made better by surgery. In other words, to have flow in a syrinx, you need to have sort of a softened spinal cord with fluid moving back and forth. So
you're talking about spinal?
I'm saying if you're trying to, sometimes you'll have a very large, you're trying to differentiate a large central canal versus a syrinx. And if there's no flow, there have been some reports that indicates that it's more likely a abnormally large central canal, but not a pathologic syrinx.
If there's no flow.
No flow.
Yeah, interesting. So we need the gold standard milligrams. That's the key. Another point, Dr. Heiss, you talked about the small posterior fossa. The other part of the equation could be the tonsils are hypertrophied. And you looked at that. It doesn't always fit the bill that the posterior fossa is small in some patients. And we operate, sometimes, one of those tonsils is massive, way out of proportion to what you would expect. So what's going on there? And is there something we're missing?
Well, I think with the genetics, sometimes the brain's too large.
Allison's our answer.
Yeah, she's going to talk about that. And sometimes it's just a disproportion. I mean, it's a small posterior fossa. It's like saying your clothes are too small. I mean, you have like Simone Biles. If you said her outfit doesn't fit Shaq because but it might be too big for her, but it's too small for Shaq. I mean, if body size is the same as brain size. So basically, if it's a disproportion between brain and the container.
Yeah.
So how do you figure that out? How do you figure out the
Well,
brain's too large for the cranium?
Well, when if you either have a Chiari or you have a Chiari 0 and a syrinx, those are the easy ones. And then after that, I leave that to higher powers.
Questions from the audience? It's a really good discussion. Yes, on the back. Right there. Sorry, it's far from the mic. Then we'll get to you in front. Sorry.
You really wanted to give me extra.
Oh yeah, come on, Teresa. There you go. Right, you got one right there.
Oh, thank you so much. Sorry. So we have learned so much. Thank you guys so much. We have idiopathic questions. So idiopathic syringomyelia, and just learning about Chiari 0 and the possibility of that. As a patient, what kind of tests do we need to have? Of course, we've had the MRIs, but what other kind of tests would help you guys to better diagnose a Chiari 0? I heard a couple different ones, but if you could just...
Any of you?
What?
What kind of
0.
test could we have to diagnose a Chiari 0 or other than an MRI?
Well, Chiari 0s look on MRI like syrinxes you see with Chiari 1. That's one thing. Second, with Chiari 0, you want to see, is there tightness at the foramen magnum? Because as much as we're talking about this being small, the end result is the most important thing, is how tight are things at the foramen magnum. And what I mean by things, I mean medulla and cerebellar tonsils and the CSF flow pathways. So that's what we're looking at. And you say, well, cine, non-cine. Well, on our MRI scans, we can see what the cross-sectional area is of the flow pathways. We can also see that on the cine. But basically the question is, well, what does the cine tell us that what's called a T2 MRI that shows CSF, what does that tell us? And that shows us flow, but we usually just look at what's moving rather than what the number is. So if we had a radiologist that was interested enough to look at the numbers and really explore things, then maybe a cine would be helpful in that case.
Yeah, I mean, I agree. I mean, also the CT myelogram as well. We do that for syrinx. Look at flow in and out of the syrinx, out of the craniovertebral junction as well, which can be helpful.
Yeah, I think that the tough ones are the Chiari 0 without a syrinx.
Yeah.
What do you do with that? There's crowding back there. Doesn't meet the criteria. Patient's very symptomatic. And we're going to be sending him Dr. Martin, and he's going to try to interpret there's so many other conditions that now, as you saw, look like Chiari. And we have to rule that out. That's our responsibility before we'd ever recommend surgery or something for that, because there's no syrinx. There's no clear evidence of a CSF flow problem that is causing objective syringomyelia. Would you agree?
Well, I think that you need a multimodality group of providers to take care of these patients in many instances. So, neurologists, sometimes you obviously need neurosurgeons, and it's a group of people and cardiologists to diagnose the POTS sometimes as well. So it maybe even rheumatologists if they have fibromyalgia. So it's managing the whole patient. It's not just about managing Chiari malformation.
We'll hear about dysautonomia a little bit later. I mean, these are really tough to tease out in isolation. Yeah, so I agree. It's hard for centers to have that team. Any recommendations there?
Well, I think that you need to develop the team. So people that have interest in Chiari should be reaching out to, the cardiologist and reach out to the neuroradiologist and reach out to other centers that have interests to develop centers that can provide the kind of care that these patients need.
Mm-hmm. Other questions? Yes, there you go. Thank you.
Got the mic. I just wanted to say this is wonderful to hear those exact words. I have not been to a full ASAP conference. I've gone to lectures. I've been searching on YouTube before Google was a thing and all that. So thank you for acknowledging that it is a comorbidity situation. I'm curious to know if anyone is involving virology and maybe like differences in blood-brain barrier or defense mechanisms within the brain and spine against things like Epstein-Barr is now getting kind of connected to MS. I'm just curious because so many of the cervical instability symptoms are very hard to differentiate between that or just the neuroocular convergence insufficiency. How do you tell the difference? Again, what kind of testing are there? What do you recommend? Or
Well, I can comment first, actually, because in my research area, the blood-brain barrier, it's a fascinating question you brought up, particularly post-COVID. No question, people with Chiari and COVID, their symptoms have gotten worse for a period of time. Some of them have not gotten better from that. Very interesting work came out of the blood-brain barrier, long COVID. I don't know if you saw some of these recent articles in Nature, high-profile journals from a close collaborator of mine in Ireland, that the blood-brain barrier has changes that are way beyond the viral illness that are broken down. What is the implication of an open blood-brain barrier? The blood-brain barrier is important to prevent things from getting in the brain and also to spit things out that shouldn't be there. But it's a really interesting question you bring up. Post-viral, post-inflammation, post-concussion, we see this. It's a parallel world I treat. We have blood-brain barrier breakdown months after the season from Irish rugby. Months. So something clearly is going on in an active way after the insult. Could be trauma, viral. So, it's a really good question, but how that interfaces here is really complex because some of these symptoms overlap completely. So your question is really quite powerful, actually. So, but I don't know if anyone else has other answers, but we've been studying this.
I can comment on that. It's a common headache that people get after COVID or even after influenza are high pressure headaches. Now, why that happens, actually, Linda Gray and I were talking about this before, and she postulated that maybe the arachnoid villus. So basically, the exit of spinal fluid gets affected by a viral syndrome. So the second thing I would say is that there was a study I recently saw that I didn't actually present about hypermobility in patients with chronic myalgic encephalomyelitis, which is basically chronic fatigue syndrome. And they found that a lot of those patients actually had intracranial hypertension as well. So there probably is some overlap between maybe the inflammatory mediators moderating the CSF in some way, maybe through decreases in its exit, that might actually produce high pressure headaches that may lead to some of the symptoms that people get with chronic fatigue that occurs after a viral syndrome.
Great point. The pediatric neurosurgeons know you get that call in the emergency room. The babies that had a recent viral illness, all of a sudden their fontanelle is tense. Imaging looks normal. It's transient. It gets better. But why is that baby's fontanelle, the soft spot up here, is all of a sudden fuller for a couple of weeks, 2 or 3 weeks post-viral? It happens. And we don't really understand that. We just say, just sit tight and get better. And it usually does. But you all see that? It's just a fascinating issue with CSF flow, absorption post-viral. But you can see how your question can lead to quite a bit of change with the intracranial hypertension, which we can't interpret those symptoms from Chiari very well either. We'll hear more about that after lunch, but these are tough conditions to tease apart. Frontal headache versus occipital, we think we have ways to do that, but treat the Chiari. Does the intracranial hypertension improve or does it get worse? These are all very difficult things maybe we can wrestle with in the afternoon. Yes.
Hi. So in a situation where scoliosis was the original diagnosis, could overtraction be the trauma that caused the syrinx, or lack of the proper imaging if the syrinx was already there and then the rod was placed? What will we do in that instant? Could a decompression still be done?
So overtraction, so this is after a correction from scoliosis.
She had two curves, a 60 degree and an 88 degree, and from that to straight. Could that have caused the trauma, the scar tissue, the nerve damage to create the syrinx, or, yeah?
I see. So overcorrection of a deformity. Does that cause spinal
Could that be
cord?
the trauma?
Well, yeah. I mean, these cases you worry about the orthopedic surgeons sometimes, because it's mostly orthopedics, right, that do the scoliosis correction, most places will get a full MRI beforehand. Yeah. So some places don't get a full MRI. Okay. This depends on the surgeon where they're trained and so on. But there can be other pathology there that could be causing the scoliosis, even though it's adolescence, it's female, it's classic, maybe idiopathic, but sometimes there's other things that are causing it. It could be tethered cord, right, that lead to a syrinx. And then if you obviously overcorrect that, you're going to lengthen the spine with one of the correction. That can lead to more neurological deficit, can lead to more of a syrinx, more damage. Obviously, there's Chiari, same thing in syrinx. You're getting the same issue. That it's hard to know after it's done. Then, like, what was the issue? But in cases like that where maybe there was something that wasn't misdiagnosed, not seen before, then you can still treat a tethered cord. There's still benefit. Of course, they're symptomatic at that point. You don't want things to get worse, and there can still be some recovery. Or if it's a Chiari, issue or syrinx, those still need to be treated probably afterwards. Just depends on the imaging.
Thank you.
Yeah.
And the reverse true as well. If there's clearly pathology seen on the spinal cord in a scoliosis patient or deformity, we just saw this recently in adult progressive deformity, but the spinal cord's clearly tethered to the arachnoid with a syrinx. We got to deal with that first, because once we distract and change that deformity with a spinal cord tethering, then we got trouble. So same with a Chiari. We have to be very, very careful in those patients. So, another question. Everyone's getting hungry. I know it. Keating.
Very quickly, this is a question that's bothered me for years. This is for Dr. Martin. I do bite and scores in every Chiari patient, so I'm attuned to how they do. I've never seen anybody that has, one side showing the hypermobility and the other side not. So why do they have this bilateral part of the scoring system? So the question for you is, have you ever seen somebody that's really loose on one side and normal on the other side?
No, but no, I would say usually it's bilateral, but occasionally it can be unilateral, where you'll get all the way down but not quite meet the criteria on the opposite side. What I would say is that it's really interesting. There probably are different forms of EDS. Like, for example, there's some where you're only hypermobile in the elbows and knees, and some where you're only hypermobile in the hands, and some when you're hypermobile all over. And these different variants are probably different syndromes with not the whole side, but there can be differences in, say, one criteria between sides. But that's probably just, sometimes people can have injury, like in an adult patient, they can develop arthritis of a joint. All of a sudden, the hypermobility may be gone. So
Interesting.
Yeah, just real. I mean, I've never seen that either, Dr. Keating. The other thing that's interesting about EDS, right, is like you mentioned, is that you can have patients, and I think this is where the problem comes in, is sometimes like the bite score is not. It's not perfect science, like you mentioned. They try to change the criteria because everyone with hypermobility is pathologic or will have problems. But you'll see patients they'll only be flexible, right? Hypermobile, like in their wrists, pinkies, hands, right? And maybe at the elbows, they have nothing below, and like almost stiff at the knees, right? They can barely even touch the ground, yet they have, the worst cervical instability in one of those patients. I showed there, if you look at their scar afterwards, and this patient was fused and was in a call-up for 6 months. Their scar widened, like, the widest scar I've seen afterwards, and clear, EDS. I mean, multiple system. And that patient, by criteria, would say, oh, this patient probably isn't that hypermobile. So there's still a lot to learn, I think. And there's differences between patients, right?
And age too. So if you have people over 40 years of age, a lot of them will lose their hypermobility. So they may have been hypermobile when they were 20, but they're no longer hypermobile because they get such bad osteoarthritis, probably from all the joint laxity of that it's interplaying with the arthritis.
What about the reverse, the reliability in a very young patient? Because a lot of geneticists say, don't even refer. It's not worth it till after 8 or 10, and it's not reliable. Do you agree with that? Well, 6-year-old, 8-year-old.
Yes, I do. A lot of them almost all of them are hypermobile.
Yeah.
So that's why the criteria vary by age.
Interesting. Yes.
Okay. Dr. Martin, I was wondering if in your patients, if you notice among your Ehlers-Danlos patients and Chiari patients, if you see more of like an ultra-rapid metabolizer with medications. A lot of the Chiari patients I know come out of anesthesia quickly. I know I do. I know I'm an ultra-rapid metabolizer through my genetics. Just wondering if that's something you see, if the prevalence is higher for that.
It's very common, but I don't know of any studies that have actually proven that. I can tell you that patients with EDS often don't respond to lidocaine. So that's a very common feature of them, but I see it all the time in my patients. Now, is it the fact that the EDS patients are looking more for that than others? I don't know, but I've seen a lot of all these different defects in metabolism of drugs in patients with EDS.
Okay, last question.
So with kind of piggybacking off the different metabolizing, and as someone that has just had symptoms that have vacillated very much, so I'm realizing that it might be because of the way mast cells communicate with the nervous system, and those change and interact with the immune system too. But sometimes it's just wildly different. I will be allergic to one thing medication-wise for 1 year, and then 3 months later a completely different one works. Like I will have hyperactivity if I take a Benadryl. So do you have EDS patients that are like counteract, or like it's almost like the opposite effect? And if so, do you all of you go into different protocols as far as like pre-op or post-op with occupational therapy or physical therapy to support those differences in either ligaments or bone abnormalities like you suggested? Are there things that you do specifically with people that have those compromised integrity of tissue as they're rebuilding or regenerating?
Well, there's different kinds of physical therapy that you do for an EDS patient. They're kind of more isometric, so they're like just tensing the muscle as opposed to trying to stretch it, basically. And we have special physical therapists at our institution that deal with the EDS patients. That answers the one question. And the other question was about multiple, like you might be allergic or have an adverse reaction one time and then not at another.
Or paradoxical effect.
Or paradoxical effect. I've not personally seen that, but I'm sure that it could happen. I will say that we treat EDS patients differently. So a lot of them, if they do have like intracranial hypotension and we give them something called a fibrin glue blood patch, oftentimes we pre-medicate those patients with steroids and Benadryl because we almost anticipate that's a very immunogenic, will activate the immune system, and often people have allergic reactions. So in situations like that, we take a more aggressive approach with our steroids and Benadryl, or diphenhydramine is another name for it. So,
yeah, great questions. Okay, everyone, we reached the lunch hour, I believe, and maybe a quick announcement just in terms of what the logistics would be. But thanks for your attention. Thanks to our panel, please.